What you have here is a workshop on teaching students in the real world, how to incorporate learners into busy clinical settings. And you have two nurse educators here, myself and Jody Dennard. I'm going to introduce Jody, and then she'll introduce me. We figured nurses work together, we're teammates, you know. We've never worked together, actually. We met once, and we're going to put this workshop on, and we know it's going to be great because she knows her stuff, I know my stuff, and nurses just do that. We just work together. Talk about multidisciplinary teams, nurses know how to do that. Jody is a nurse who works in the OR here at Hamilton Medical Center. She's the OR educator and clinical resource nurse, and she received her degree in nursing from Ohio Valley General Hospital School of Nursing in Wheeling, West Virginia. She received a certificate of perioperative nursing in 1993 and is currently completing a degree in nursing education from the University of North Carolina. During her time at Hamilton, she has served as an outstanding role model, I added that, and a preceptor, her bosses told me that, and is the go-to person before you enter her OR suites. Okay. So let me get started with our slides. I'm going to give some credits here to the North Carolina AHEC. They have produced a lot of preceptor development programs over the years, and Denise and I used a lot of their materials with permission to develop a national preceptor development program toolkit that was dispersed throughout the country. And I've pulled a lot of information from those mentors that set this up for us and from what Denise and I have done. And so what I want you to know is anything from our workshop is public domain. You can pick and choose it, use it any way you want. Please use it in your teaching setting. Our objectives today are to describe practical steps for building a successful learning environment. I will read these objectives. We want you to learn 2 new teaching skills and know when to use them. We're going to try a little role play. If you're not interested in that, we'll do it ourselves, but we love audience participation. And you'll learn ways to keep teaching fun and patient care flowing. It's got to be fun. It has to be fun in the clinical setting, or it pulls you down. And teaching can be tons of fun. We're going to discuss the potency of role modeling in busy clinical settings. Okay. The workshop outline is that we are going to talk about preparing and welcoming the learner. And this is very important. There are studies that show if you do not take the steps that Jody's going to guide you through first, if you don't do that, just take a couple of hours in a busy clinical setting to orient your learner, show them where the bathroom is, where the coffee mugs are, that kind of thing. It severely delays their clinical learning curve. Some studies show that the learner is put behind 2 weeks if you haven't spent 2 hours in orienting them well. And she's got a very detailed plan showing you how to do that. That's our main objective there. And then you'll learn 2 techniques called direct observation and teaching bites to keep learning fun and fast and quick and patient care flowing. We're going to talk about scheduling topics, real-time learning, and creative ways to build on what the learner already knows. Okay. Later in the program today, you're going to hear from Dr. Mahmood about how to assess the learner, okay, and know where they are on that learning curve. And then we want you to tell us about some of the memorable mentor traits that has made a difference in your life. We want you to talk about that today. Before a student arrives to you in the clinical setting, now I know a lot of you are educators in a classroom setting. When you send students out into the real world, a number of things have to happen. Those of you that teach out in the real world in a clinical setting need to know that the affiliation agreements, the student insurance and certificates and all kinds of things are handled at a higher level. Students are, by the school, tested, they're checked off on all the standard procedures they need to know before they get there. Okay? A basic fund of knowledge is tested and found to be acceptable to minimum standards. Okay? And basic clinical procedures are found to be acceptable. They have beginning level professionalism, and every student's different, as you know. You're all educators, so you know every student brings their own culture, their own way of being, their own family of origin, and they bring what their teachers have taught them. Okay, student immunization records and all those kinds of things are taken care of. AHECs facilitate the process when needed. A school ID badge is to be worn at all times, and once all that happens, the student is ready for you, the clinical educator. And this is where Jody's going to talk about what we do next. A student's walking in, first day, what's going to happen? Are we going to set them up for success or let them fly on their own?
Well, this is a great program because we have gotten these students for 10 or 15 years now. Some of our surgeons will agree to be a preceptor to the med students. And I get a call from medical staff services. And they say, Dr. Jones wants to bring in a med student. When can you teach them how to scrub? Or when can you teach them? And as the program has evolved with us at Hamilton, we thought, well, what do they know? Then they didn't know anything. Now with Paula and Blue Ridge, we have all this covered. So at first we did HIPAA, we did all that, OSHA, we did the vaccination, and now we get them from you, and we. How it happens is I get a call from medical staff services or from a surgeon in particular and says, I have this med student, I want him to come scrub with me tomorrow, I have a case, when can you do this? There's reality. Tomorrow, I have this case I want him to scrub with me on. And I look at my schedule, and this is not all I do. I work in the OR, I have RN students that I teach to work in the OR. So how am I going to fit these people in? Well, I do. I do because one of the things that we believe is we do not want a medical student that we don't know anything about coming into our OR, taking care of our patients. We want to make sure they're competent in knowing what they're doing. And most of them, now some of them are starting to get there. Most of them have never scrubbed before. So I bring them into the OR. Well, let me just stop there a minute. First of all, I talk with them over the phone. We have an agreement of when they can come into the hospital, how to get to the hospital. I make sure they know that. I make sure they know what entrance to come into. And I tell them who I am and who their first person that they're going to see that morning that they know. I'm expecting them. Tell them Jody's expecting them, and then they bring them to the office, to my office. And I bring them into the office and introduce myself and try to make them comfortable. We exchange, where are you from? What are your expectations for today? Tell me where you are in the learning process. And here's my checklist here. And I have a checklist that I've developed over time, over the years, because we have the Joint Commission looking, we have the state looking, we have other doctors looking. What have you shown them? And if I don't write it down, I don't remember it, in 6 months. So I have this checklist that I've developed that I have added to over time. But the first thing I want to do is try to make the person welcome. And once we talk about who they are, where they're from, want to make them comfortable. Most of them could be my child. And the one thing I think about is this person could be taking care of me, in the future. So I want to give my best to them so that they are going to give me their best when I need them. So I'm investing in the future, and that's how I look at it from that perspective. But then we go to doing some mundane things like walking them and showing them where the lounge is. And the other thing that I think is important is to stop and meet people along the way. So we maybe run into a surgeon and I'll say, Dr. So-and-so, do you have a minute? I'd like you to meet Joe Smith. He's a med student. He's going to be here for 6 to 8 weeks. He's going to be working with Dr. Jones, and introduce them to the secretary, make sure they know, the secretary knows them because that's who a resource person they can go to. And then we go into the lounge, which usually has a few people in it. And I know they won't remember their names, but one of the things about med students in the operating room, everybody needs to know who they are. And at that first day, they don't have any name badge or anything on. So I try to introduce them to the staff so the staff knows who they are and what they're going to be doing here. And if you've ever worked in an operating room, if you see somebody different in there, you want to know who they are. Because they can make a big difference between contamination of a sterile field and the ruining of a surgical case and starting all over. So they're very protective, as they should be, of the surgical environment. We do that, then we go back and take a tour of the operating room, and I show them all the operating rooms where the main schedule sits, take them through the department as the patient would go through the department, so that they know how the process works and what they're going to be doing in the morning to follow their patient. Or maybe they want to come early and review the history and physical before the surgeon arrives so that they can help prepare themselves for what they're going to do that day. And they don't always know what they're going to do the next day, which is an issue. Some of us can prepare for a case we're going to take care of tomorrow. In the operating room, things change all the time, and they may think they're going to do a laparoscopic cholecystectomy, and they end up doing a trauma case that just came into the ER. So they need to know where they go. But on the way, we have to look at those things like fire extinguishers and evacuation routes, and how do you get out of here? Those things that we think, that's never going to happen to me, but you know what? We had a fire drill the other day, and it was real. So they need to know, and a lot of them now, as I look at a fire extinguisher, this is funny, but they didn't know what the acronym for the use of a fire extinguisher was. They didn't know what the acronym for putting out a fire was. And they look at me and because it's something everybody needs to know, so I made sure that I brought it up. But I'll tell you what, the new med students they're just right on it, pass and race, they got it. So we do all that good stuff, and as we go to the pre-op area where the patient is admitted, to the post-op area, to the SICU, and we make our rounds, I'm introducing them to all those people in those areas so that they know who they are as well. When they see them, they know they might need to see a friendly face. Have you ever been somewhere where everybody looks like, who are you? If you see a friendly face, somebody you've seen before, you can walk up to them and ask them questions. So they have that resource from us as well. Some other things, then what we do, then we settle down and we talk about what practically they're going to do. They're going to need to know what sterile technique is. Have you ever scrubbed before? Have you ever gowned and gloved yourself? So on and so forth. So what I find is easiest to do is to do it with them. And I will just scrub right beside them and use the standards that we go by at Hamilton, which are AORN standards. It's our professional organization, and we're active in the professional organization, and we use their recommended practices in our everyday practice. So we do that. I take them in an operating room. I have them gown and glove, and it is such a eye-opening experience for them. You know, you've watched Grey's Anatomy and all those shows, operating room shows, and you've seen them do it, and geez, me and several of my colleagues back there, when we watch them, we say, they didn't do that right, you know. But here we are, and I show them, I do it right beside them and show them how to do it. And tell them and encourage them that this is something that takes practice. That it's not something that you do every day, but you will. And as you do it every day, then you're going to learn how to do it. And then we go, after we practice scrubbing, gowning, and gloving, we work in a sterile field so they know how to move around. And I talk to them about what I want them to do the next day. I think this gives them an idea about what's expected of them in the operating room, and knowing what your expectations are, just like Paula said, that 2-hour investment versus a 2-week setback is going to be such a wonderful experience for them. So we talk about the expectation tomorrow. Tomorrow, what I expect of you when you come in, you know how to come in, you know, we go over that again to reinforce that, is you're going to go get your gown and gloves, and I show them where they can get them. You're going to go to the operating room that your surgeon's going to be working in. You're going to be setting up your gown and gloves for donning in the morning, separate from everybody else. So that if you do something wrong, you're not messing anybody else up. Okay? Everybody's watching you. It's like being on stage. It is. But if you mess it up, you just try it again. If we let them come in there and let our scrub techs or scrub nurses gown and glove them all the time, they're never going to learn how to gown and glove. So I also tell them the next place you go to, they'll be very impressed that you know how to do it. So I want you to learn how to do it here. And I want you to learn the right way too. The other things that we have to go over are MSDS. Everybody know what that is? We have to do. Does everybody know what SCIPS is? Anybody ever heard of SCIPS? I know our staff, our nurses have. It's Surgical Care Improvement Project, and it's a core measure that's been developed by Medicare, Medicaid, that are standards of practice that we have to go by, and we're measured by how well we do within the country. And I talk to them about how important that is and what their role is while they're here scrubbing with the surgeon in SCIPS. And I also talk to them about their role. One other thing I was just policies. Dude, it's a big deal. Anybody got any policies you have to go by? Hello? Policies. When you scrub, you have to do a sponge, needle, and instrument count by our policy. You must participate. Time out. National Patient Safety Goal. You must participate in the timeout. That's our expectation of you. So we've gone from coming in to SCIPS to timeout to policies, and then I show them a film on sterile technique just to kind of, put them in that picture. How are, just to show them. It's an AORN recommended practice film, so it's great for them to watch. And then fire prevention, which is another issue that we have in the operating room where we have great potential for fire. So we do that as well. We end the day with taking the checklist that I have and we go over it one more time. We check it off. I have them sign it. We stop. Do you have any questions? I ask them. Would you like, and I offer them a gown and glove to take home to see if they feel like they want to be better practiced to do it. And some of them do, so we gladly provide that for them. And then I also offer them my card, and I tell them that I'm on their side. Hey, I'm rooting for you. I am a resource for you at any time you need anything that you feel uncomfortable asking anybody else. You can always come to me to ask me. So that is what I do in the real world. Hopefully that only takes two and a half, 3 hours at the most, unless we get interrupted by something. But that's a lot to do in that short period of time. But it is something that I feel very strongly about, that I have been doing and that I want to do, because, again, these are people we want to invest our time with, because they're going to be taking care of us in the future. Okay, Paula.
Jody is such a good public speaker. She did that without going through slides. I have to read the slides. But anyway, these are some of the things that she talked about, and we'll just skip through those. She did a great job.
Sorry, I forgot about them.
I thought, oh, should I do the slides? I thought, no, I want to pay attention to her. And that's what we do in the clinical setting as well, isn't it? I've taught in the clinical setting. I've taught in universities, in nursing school, and in many other settings. And one of the interesting things is we're always shoot from the hip, so to speak, aren't we? As educators, it's like, whoops, okay, let's punt here, let's back up. We need to go back here and take care of this. All right, now you're ready to go, right? So teachers teach best and learners learn best when expectations are clearly stated. You'll see me, you'll hear me say this several times, and Jody also referred to this several times. One of the interesting things that she said over and over again was, this is what I expect from you. And tomorrow, this is what I expect from you. And when you leave this rotation, guess what? You're going to be one of the best of the best, because you've done what we've expected of you. So all students, don't they want to know what A looks like, right? And so how are they going to know that if we don't tell them? If we don't spend that time? And of course, she verifies learning. So what I'm going to do is talk about direct observation as an evidence-based best practice teaching tool. And this is a tool that helps you understand you do not have to teach it all. That school and that student is responsible for the curriculum. You are responsible for doing exactly what Jody described. You're here for this experience. This is what I have to show you. The patients that show up, those are our teaching tools, and those are the experiences that you will have. And we will have a teaching tool, we will have a direct observation and a teaching bite on maybe 3 out of 4 of the patients that we see. Okay. My favorite expert quote is this one right here. William Osler, he's a physician, and he said, there should be no teaching without a patient for a text, and the best is that which is taught by the patient himself. So you've got the busy setting dilemma, and I'm putting all of us that are educators into the setting of, I'm a preceptor, now I've got a student, and here's what I need to be doing. Those of you that are nursing educators, as you develop your preceptors, please keep these things in mind. When I was a nursing educator, I was on the phone a lot with my clinical preceptors, guiding them, teaching them in the art of teaching. You're here today because we see a great need in this area. Hamilton's thinking about a residency program, growing a lot. You've heard Denise talk today that we're going to need to grow a whole lot more nurses, nurse practitioners, PAs, and physicians, and dentists. So how are we going to do that? We might be great clinicians, but awful teachers. That's a different skill set. You don't want a teacher to do nursing, right? Okay, so we need to teach healthcare clinicians how to be good teachers. It's a whole different skill set. And that's what this whole program is about today. So here you are in a busy clinical setting. You've got all these patients to see. You've got your usual routine. And patients or students slow you down, right? Students slow you down. But they don't have to. Okay, so that's what this section is all about. You need to know what you're responsible for. You provide, as a clinical educator, learning opportunities, and those are the patients, to practice professional behaviors, skills, and to apply knowledge. And then you also role model the profession. How do I do this? I've got all this book learning, but how do you actually do it? How do I be? You keep it simple and focused. Expert preceptors have developed observation skills over time. And in your packets in our section, there's a reading that we've included from the North Carolina AHEC that is phenomenal. It's just a good classic bit of information on these observation skills. They look for teachable moments, and they offer simple, focused teaching bites for specific observations, one patient, one procedure at a time. Direct observation works because it can be done in many different settings. I can walk along beside my students, and I see something in the hallway that's happening. Let's say an elderly client that needs to be put in a wheelchair immediately. Well, I'll take care of the patient first, but I'm role modeling, aren't I? When I do that, everything that I'm doing, that student is like watching, right? So how am I as I'm doing that? What's my attitude, my knowledge, and my skill level as I'm doing that tiny little thing that I would do anyway and not even think about, right? I wouldn't even think about it, but I'm being observed, okay? So then after we've taken care of that little emergent situation, then I talk to the student and say, so what did you see there? What did you notice? And have them teach me. Students give, I tell you what, as a clinical educator, I love having students because they keep you on your toes, they ask the most marvelous questions, and they have you take a quick look at yourself, don't they? It's like, wow, thanks for teaching me that. I learned something from every student I ever taught. Everything, every student. It was marvelous. Okay, direct observation also works because, and I get excited about this, so pardon me, I love this work, and I love talking about the developmental model of beginning preceptors, newbies, becoming marvelous clinical educators. I've seen that over time working with the AHEC, and it's just so fine. And those of you in the educational field, in the institutions, you see that in your preceptors, don't you? Yes, you do. Yep. Okay, we need to show them, just like students, we need to show them how to do this. So direct observation establishes a baseline and sets learning goals. What did Jody do? What do you know? Let me see how you do this. Have you ever done this before? Quick assessment. Then she's reinforcing their learning in a positive way, but she's also correcting the errors. And I'm going to show you how to do that in a positive way in a little bit. A lot of new preceptors are afraid to give feedback. A lot of new preceptors are afraid to do direct observation. They'll think the student is shy about watching them. Yes, the student's shy about watching them, having them watching them. But shouldn't we do that? Yes, we should. Okay. So we'll talk about how to do that. Direct observation, how you do that when you are looking at professional behavior and attitudes. This is a difficult one, and so what I'd like to do with Jody, we're just going to do a little quick role model. We're punting a lot as we do this. As I said, we haven't worked together before. I'm a student, and I've got it. Well, here, let's just do it this way. I am helping an elderly lady as a nurse walk down a hall. She smells awfully, and she needs a bath. And I'm really offended, and I've got a new lab coat on. And I'm like walking with her in a way that's like, oh, God, but I'm not letting her see me because I'm trying to be professional. And so what do I do? How do I do this? So what would you say to me as you watch me walk down the hall with this older lady, and I'm holding her inappropriately, and if she falls, I'm not going to touch her? What would you do?
I'd say, can I help you, Paula? Do you need some help with this?
Here.
Yeah.
And I'm
Would you like me to get you a wheelchair for this lady?
That'd be good.
Okay. That might be helpful, huh? Okay.
And
then let after we get her in the bathroom, let's go talk about this. Okay? Okay. Let's talk about your body language and what you were
Was it good? I hated the smell. I mean, how could you do that? That was awful. I was choking.
I know.
I didn't want to see it, but it was
I
awful.
know, but maybe we could. Well, we'll take care of that later. But boy, were you speaking loudly through your body language. Okay, so you're going to encounter that in this job.
One of my teachers said I should breathe through my mouth, but I didn't want to even breathe through my mouth, so I wouldn't smell it. She said that's an old nursing technique, but I don't know how to do that.
Well, let's go practice how to do that.
Okay. All right. So she took care of the immediate situation. We placed the patient in a wheelchair, got him off somewhere else, and then she took me aside. Okay, you don't make corrective behaviors in front of a patient or in a place that is in a public setting. Okay. Next one is the fund of knowledge. This is something that as a on-campus faculty, nursing faculty, that I found was very difficult for new preceptors. I don't like to ask questions because then they stutter and then I feel bad. And nurses tend to feel bad when other people feel bad. We're pretty empathetic folks. So there are ways to do that, and there's a workshop that's going to help you through that, and the nurses in the room. I hope that you'll be able to teach your clinical faculty how to ask questions in a different kind of way. That's a great one right there that you can build on. But one of the interesting things that you can do is just ask for their thoughts. You can observe the patient and family education that they're doing. Ask them to educate a patient or a family as you watch. And then you can build on what they know. And then request literature review on something that you're interested in, okay? And then ask for more in-depth questions. And usually I do that away from the clinical setting. Those discussions take a little bit more time. And you've got to keep moving in the clinical setting. When you're looking at clinical skills, you definitely need to observe. Now, Jody took you through what she does. Don't you want students to know exactly what to do when they go into the OR, right? So she is right there with them. They're mirroring her. They practice and they rework, all right? So one of the interesting things, I teach part-time now, and I take students into a mental health facility. And that's a whole nother learning skill, set of skills that they're learning. But a lot of them, these are senior nursing students who may or may not be able to take blood pressures in a very routine, quick manner. And so here they are. It might take a good 3 to 4 minutes. We've got a line of 30 mental health patients who are pretty intensely irritable, wanting to get on to something else. And we're taking on the blood pressures, and I do this on purpose so that these students can practice, doing blood pressures over and over and over again, right? And so it's, just being afraid to touch the patient, and is he going to hit me? And then, well, is that right? Oh, I don't hear it right. They've got the stethoscope. Stethoscopes are supposed to be turned towards your nose, right? Okay, a lot of them don't know that, and they can't hear. It's a very noisy environment as well. They're learning real world blood pressure taking, right? And so we're working at that. What I had to do as a clinical educator was have a little mini class on blood pressure taking before it went out to the clinical setting. I didn't know that they've done a lot of things. They've been served IVs, they've done a lot of cool stuff, but they don't know how to take blood pressures quickly and efficiently. They can get the right numbers, but can they get it done in the real world? No. And we talk about that, and this is their senior year, so it's a good thing. So those are the little kind of things, and I have them do that. I have 8 students, 9 sometimes, and we'll take care of that before we go into the setting. We already did our role play, but I want to go over something with you. This is you're a student, and this is your first day of clinical training. You're hurriedly welcomed and oriented by an overworked, friendly staff. So you feel welcome, but it's like, wow. And then your preceptors had to run into an exam room. Now, again, I am a person who trains physicians how to be good preceptors out in the community setting. So a lot of my examples come from that, but you'll be able to relate. And so the preceptors had to run off and go see a new patient who needed something immediately. And so you as the student, you've been asked to help Mrs. Smith into the next available exam room, but you're not sure what that is, where it is. Everybody's too busy to ask. You don't like her smell, and you want to get away from her right away, and she's leaning on you for support, you have a new lab coat. So the preceptor, as you step out of the exam room and the patient's taken much of your time and the staff members want to move you along to the next patient, but this is a very green student and this student is in trouble. And they haven't had a good orientation. They don't even know where the bathroom is yet. And else, I want to tell you, in medical education for the physicians in the room, the LCME requires that you make sure that that student knows where to place their things safely, and their things are stored safely. Or LCME, which is the accrediting body for medical schools, can say, this is not right, and the school gets in trouble. Okay, so what you would do is what Jody did. Let's take care of the immediate situation. Patient gets taken care of first. Let's get this student over here. And what a lot of the physicians end up doing is assigning the checklist, the orientation checklist, and the orientation to a staff member, the friendliest staff member that they have. So, back here, when you looked at us and you watched the attitudes, you could see my attitude through my body language, right? And through my voice inflection. And you could see her attitude, knowledge, and skill. Now, she had a tender way with me. She might have used a different way with me because I was definitely little, and I was in trouble. If I were an aggressive student, she might have come to me with a different set of attitudes and skills in that way. Okay, so teaching efficiently. This is the teaching guide. Here's what we'll do. She used it, but I'm going to take you through this. It's a formula, just like anything in clinical education. We have these formulas. What was done right, what needs fine-tuning, how to improve, and when to return demonstration. You heard her talk about it. If I have a student, let's say I've got my student working on their blood pressure, we've had our little class, a refresher class, and the student is still fiddling, I might step in and role model and do it if that patient is getting very irritable in mental health. And then, we'll talk about it in a moment. So let's come over here, and I will say, I noticed that when you were taking that blood pressure and the patient was squirming, you didn't look in her eyes, and you didn't say a kind word, but you were great at your technique, but you didn't say the kind word. So here's what I want you to do next time. Okay, and then I would describe what I did. And let's go try it again. Come on, I know you can do this. Let's go try it again. Does that feel better than saying, that was awful? Yeah, you could have gotten hurt. And I've watched many nurses do this. You're gonna get hurt if you don't do this. Right. Okay. Well, that feels bad, doesn't it? Okay. And a lot of people that have come out of school tend to have been taught that way. So, that's how teachers teach, okay? But we can change all that. We can change all of that. All right. Here's another one. You watch your new employee learner perform a procedure, and he or she could do better at it. You notice that she seems to be unaware that she should be better at this by now, and she's going to survive in this fast-paced setting. She'll need some tips right away. I've taken care of that with the blood pressure. Here's one about attitude. You walk into the break room and you see your mid-year student in an intense conversation with staff, and they're talking about your cruel behavior with a non-compliant patient whose healthcare practices are pretty self-destructive. So you have a reputation, though, with your staff of being kind, skillful, and straight talking, and your patients actually like that about you. Okay. So you attempt to offer consolation to this newbie who's going to come, and they'll eventually understand what therapeutic dialogue looks like and when you need to use it and the different styles that you use. But for right now, the student's pretty upset. Does anybody want to model that at all? Or do you just get that? Do you understand what I'm saying? Okay, got it. All right, so we don't need to do that. So one of the things I want to talk about here is scheduling. It's really important. Jody's talked about that first couple of hours. And again, now she does a very intensive orientation with procedure, right? So hers takes a little longer. But an office person or a new nurse on a unit, where things, we've got our checklist, by the way, in your handouts there. That checklist you guys can use as well. Then have a written schedule for the student. One of the things they found in those studies is that if the student doesn't know where they're going to be, well, closely where they're going to be, every moment for the first week, that terror level is so high. And you all know as educators that when the stress level is too high, learning stops. When the stress level is just right, learning is enhanced. So this is one of the things that a lot of people do. Clinical preceptors will develop a schedule, and then they post it in a prominent place, or they have, depending on where you work. And some units have actually posted that in the nursing station where the unit clerk can go, hey, there's a cool procedure happening, blah, 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 you want to go? And so the whole unit is part of the teaching team, and everybody gets involved. And when that happens, fire is lit under the staff, and it energizes the staff. It can be a really cool thing. You elicit, as I said, and then ask for verification of learning. When you need a break, this is something I talk to preceptors about a lot. I need to check my time. Oh, yeah, okay, we're good. Students learn in a variety of settings. You don't have to do it all. I tell this to clinical preceptors all the time. Schedule that student someplace else. These are places where the Georgia Rural Health Experience folks take our medical students, our nurse practitioner and PA students, and then inside the hospital, they can go to professional committee meetings. Have them go with you. They need to learn that stuff. And then grand rounds, and then following patients through diagnostic procedures in the hospital setting. The greatest teacher in the world is the role modeling that we do. You said it, right? And I hate it that we say those kinds of things. Don't do what I do what I say. Okay, but the greatest teacher is role modeling. If you never, ever offered a little mini lecture, a teaching bite, or feedback, your manner of interaction with the patients and families, and just the being and the doing of what you do, that is the true teacher. And then many experts say very little, expert preceptors. They don't teach a lot. They actually walk alongside the student, give them opportunities to learn and do and use their knowledge and be the professional that they can be. And then who was your most memorable teacher? Here's where I'd like to take just a few minutes. Name a quality of your favorite teacher. Very straightforward?
Very strict.
Oh, very strict. You like that. I did too. I was a little afraid, but I knew what I had to do. And I knew what A looked like, and I wanted to be an A student. Very strict. Okay. Was it kind strictness, or was
very kind?
It was kind strictness. Okay.
But you knew what was expected out of you.
Yeah.
She accepted no less.
Gotcha. Okay. What else? Patience? Oh, yes. Oh, my God. Oh, my gosh, yes. I can't believe you can't get that done. You're going to be kidding. Oh, my God, you guys, they don't teach you anything in school? Oh, my God. Oh, Lord. And then, oh, okay, so you haven't mastered that yet. Okay, cool. Well, let's master that. Okay, sure. What else?
Supportive, but not standing over you constantly. I couldn't
Not
stand for
supportive.
somebody to watch every little move I made.
And I understand. So supportive, I'm going to say it again, supportive, but not hovering.
Right.
Yes, got you. That's so true.
One of the biggest things for him was the instructor in middle school. He was always willing to say he didn't know.
Oh, yes.
I mean, we get this bunch of smart kids together, we would come up with some crazy questions, and he would go, I don't know, but I'll tell you what.
Excellent. And why don't you look that up and bring it back to me tomorrow, and we'll talk about it at lunchtime.
Exactly.
You need to teach me that, because I don't know. How cool is that? I teach that to physician preceptors because they don't have time to look it up at night. The cool thing with nowadays, nurse practitioner, PA, and physician students bring their little handheld devices. They'll go, I don't know. Look it up. And the preceptors are like, oh my God, this is fantastic. Hey, would you look up blah, blah, blah? Would you look up? And one of the physicians said, man, I've got my own personal library. This is phenomenal. I'll teach. Can I have some more students? That's music to my ears because I have to find placements for these people. And our class sizes are increasing, aren't they? So what other characteristics, and how close are you to that ideal? Think about that preceptor, and then On your own developmental model, your own developmental process, how close are you to that model? We're never finished, are we? Not ever. So in summary, start small, build skill, use the patient procedure and material at hand. Use that moment, use that moment, use that moment, use that moment. And stop for a while. Just go about the day. Let's go do these things. I'm tired of talking. Okay, let's go do the next one. Here's what you did right. Here's what you need to improve. Tomorrow I want to see this. Okay? Okay. And we're moving. We're moving. We haven't slowed down. You haven't slowed down. Okay, we got a second. You know, we've got 5 minutes before the next thing. What do you want to know? Or, we've got 5 minutes before the next thing. Can I go a little deeper with you about this? And I asked the person for permission to take a little moment with them and give them a little bit more knowledge. You're going to hear a lot more about the skills. We've just given you the tip of the iceberg. Okay? And remember what you are responsible for. Clinical educators, please remember, you do not teach it all. You are not responsible for it all. The school and the student are responsible for the curriculum and passing exams. Okay? You are responsible for providing the opportunities to practice their behaviors, their skills, and their knowledge, and to apply it. And then you provide a daily example of excellence, your highest vision, your highest vision. And then we cover these important points. The welcome and orientation of the student, I want to say it one more time. Educators, by the way, I learned this way back when I was learning how to be a very new nurse educator. Say it 3 times, 3 different ways, it'll stick. That's also a marketing tool I learned from my nephew. He said, oh, we do that in marketing. You have to say it 3 times before it goes in. And you say it 3 different ways. So I'm going to say again, that welcome and that orientation is so important. You can save so much time and frustration for yourself and your student and have better outcomes for your patients if you'll just take that time to do the orientation. And have the checklist, all the tools are in there that you need that these people have developed over the years. Make them yours, make them stick, and use them. Okay? That's my saying, please do this. And then keep learning fun and patient care flowing. I didn't get to model that a lot. But if teaching isn't fun, it just isn't fun and it's not good for the patient. That's my main thought there. But it also isn't good for you, and it also isn't good for the student. So keeping it fun is going to be